Hi everyone. Today we're going to do a basic introduction to cardiac scanning. At the end of this, you should be able to pick up a probe and start getting some basic images. We will go through how to position the patient, how to position the probe, what a good image will look like, and also the most common mistake that beginners make. I also want to introduce you to our cardiac simulator, the HeartWorks simulator, that is available for your use at the Peter Lloyd Hospital. Please talk to us about it. It's a really great resource owned by the residency program. So our first view that we're going to look at is the apical fore. So the apical fore is acquired by scanning, as we say, from the cardiac apex. The indicator is pointing to sort of towards the patient's shoulder, kind of in the 3 o'clock position, and then pointed towards the kind of the top of the chest. So as you might imagine, the angle of the heart is. And this is the view that you're looking to see. We want this nice straight septum, the LV apex in the middle of the picture, and the RV more off to the side. So the anatomical structures that you would visualize in this view would be the left atrium, left ventricle, right atrium, right ventricle. So just a quick recap on that. So positioning your patient, you're going to turn on the left side, you're going to pick up your probe. Your indicator is going to be pointing to the 3 o'clock position. You're going to feel for the cardiac apex beat, sort of anterior axillary line nipple. Point that probe kind of in the direction of the heart, and then you're going to look on the screen, and this is what you want to see: a nice perpendicular septum, LV apex centered, and both valves opening. Now, the two common mistakes that we're going to look at here is what happens when your probe is too medial, or when you foreshorten the heart to enable good contact with the probe. So these are two common things we'll be looking at. So this is the first picture just to show you what a reasonable apical fore looks like. We could be more on this apex, so maybe a bit of turning the probe in this direction would give us that, but this is not bad. So we have an LV apex, nice perpendicular septum, and here we have our RV, tricuspid, mitral valve with left atrium and left ventricle. Here's our first kind of common error. So what happens here is that you have the right place where you place your probe, but because you want to get really nice perpendicular contact, or nice contact with the chest, you put the probe down in a very perpendicular fashion to the chest wall. And so you cut the heart really short. So what you have to do in this instance is to bring that probe handle down so that the beam points up more into the chest so you can get the full atrium. So really dig into those ribs and get the heart nice and long is what you would do to fix this. Now the next common mistake is, or beginner's mistake, is to go too medial in the chest. So it's easier, so you can see here we're really not apical at all. We've shifted way medial, and what we see is then this kind of flat, sort of more horizontal heart with an apex that's not in the middle of the picture. The septum is at an angle and not perpendicular, and the RV is centered. Now, how do we fix that? Well, we have to move the probe over more to the apex. So this would be somewhat what that would look like. So you would lose contact. You'd move the probe more way over to this side, over here, and then your picture would come into view. So now you would just rotate the probe to open up those valves, and there is your apical fore. No longer flat, but a nice vertical heart with perpendicular septum and LV focused. Okay, this is just another demonstration of what that looks like. So we're way too medial. We're not cutting through the apex here at all. The heart's just not looking like an apical view. Now we're moving the probe out towards the apex, finding a new contact point, rotating the probe now to get that heart to open, and there is our apical fore. So that is the essence of an apical fore. Takes a bit of practice to get that contact and that nice angle. The next view that we'll be looking at is the parasternal long axis. So the parasternal long axis is in the sort of third intercostal space. The indicator will be pointing towards that patient's right shoulder. So this is the only view where the indicator is pointing towards the patient's right. In all of the other views, the indicator will be pointing to the patient's left. And this is kind of what we want to see in that view. So we want to see this nice open heart. We're mostly looking at this area. So if you don't see the apex in this view, that's fine. And in fact, we seldom do. It's really looking at this area of the heart. And the big thing to really focus on is to find this nice horizontal heart. So if your heart is very vertical, you have to go up a couple of spaces, 1 or 2 spaces. So we'll just run through that. So you're going to turn the patient on the left side. The probe indication is going to point to the patient's right shoulder. You're going to be parasternal, so very close to the sternum to find that window between the lung and the sternal border. Around the third interspace, you want to see a nice horizontal heart. And common mistakes is that we're either too low or too high on the chest wall, or you're moving the probe too far out from the sternum. Okay, so here's what that looks like. So a nice horizontal heart, and we're mostly focusing on this area. Okay, so not every time you put the probe on the patient's chest, you'll start in the right spot. So we're going to fan through this heart to show you what it'll look like at different depths in the chest. So when you're very anterior in the chest, you're going to see this pulmonic valve. As you move into the right angle, the aortic valve shows up. And then as you go too deep, you're seeing the tricuspid valve. So kind of in the middle of pulmonic and tricuspid is where you find the aortic valve. And then you just turn the probe to get that nice long heart. Okay. Let's play through that again. So you have tricuspid valve, aortic valve, and then as you come more anterior, there's pulmonic valve. Now going back again, there's aortic valve, tricuspid valve. Coming back up, there's aortic valve, and now we just rotate the probe till we open that heart and it's nice and long. And that's how you get a parasternal view. Now, common mistake, as we said, is to move that too far out and too low down, and it gives you this kind of hybrid view with the heart too vertical. So when you see this kind of picture, move your probe up one interspace. Next view is the parasternal short axis. So parasternal short axis, so you can see now the indicator is pointing to the other shoulder. So we've basically gone 90 degrees from the long axis. So this is the way I get the short axis, is I'll get the long axis first and then rotate through 90 degrees to know that I'm in the short axis. And the reason for this is that the heart isn't always at exactly the same angle in the chest. Some hearts are more vertical, some hearts are more horizontal. And this is what you want to see. You want to see this really nice round left ventricle with your two paps being equal size. And this is to make sure that you're cutting perpendicular through the chest. So a summary then, your patient will still be on their left side. You will be pointing the indicator to the patient's left shoulder, so 90 degrees from the long axis. Your probe position will be parasternal in the third interspace like it was. Just something here, and if you see your image, you want to see this nice round heart with your two equal pap size. And the most common mistake here is that people don't cut the heart perpendicularly, so they're off on an angle. And so instead of a nice round heart, we get this kind of elliptical heart, which will change cavity sizes as well as wall thickness in our assessment. So how do I find my parasternal short? So we start with the long axis, we rotate through 90 degrees, rotate, rotate, rotate. So now we're at 90 degrees, and now we just fan down into the heart but that wasn't quite enough, so we also did a little slide. So those are two things we can do to just move down the heart. And then we find this nice round ventricle with the two papillary muscles. And you can see here, my cut is perfectly perpendicular. Okay, so unfortunately patients don't come with this picture, so we have to depend on what we see here. So what you really want to look at is round with equal size pap muscles. And if you don't see the right ventricle, like here it's cut a little bit, you can try and move down one interspace. Okay, next step. So here we go, just showing you that again, going through 90 degrees. At that point we fan, and then slide. Okay, so those are the two motions you can use. Fan, where this part of the probe stays still and we just move the beam, or a slide where the whole probe slides onto the chest. Okay, next view is our subcostal. So we now come in and we use our liver as our ultrasound medium. So you're going to slide on that liver border and point into the chest. Our indicator is pointing kind of straight to the side here at 3 o'clock. And we're going to kind of see an apical, so it looks like an apical view, but turned on its side. So position for this patient will be supine or semi-recumbent with legs bent a little bit to make it easier for the stomach to relax. The patient probe indicator is sort of patient left shoulder or 3 o'clock. You put the probe position subcostal on that liver border, and the image looks a little bit like an apical turned onto its side. So this is what it looks like. Here we start our subcostal scan, and as we said, we're not always at the right depth. So sometimes we're too shallow. Here's the RV, very shallow structure. Then we see the aortic valve next up. And then we get our, so as we dip our probe down, we get this nice subcostal image. So RV shallow, then aortic valve. If you're still seeing aortic valve, get that probe pointing handle up, the image pointing deeper. This is another part of what we can visualize subcostal. If we turn 90 degrees and we scan to the patient's right, we will find the IVC. Make sure you don't confuse it with the aorta. So scan, 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 and there's the IVC. We can see the hepatic vein there, and the aorta would be pulsed off, so make sure you don't confuse. And that is the end of today's little talk on POCUS. Hope you'll enjoy playing with it. Please come and use the HeartWork Simulator. It is a fantastic resource, and as you can see, can really teach you a lot about how to apply the probe, how to move it, and how to correct for mistakes. See you in the OR. Have fun scanning.